Okay, today I will talk about the three anatomical findings. And first will be the anatomical findings on the upper masseter and ultrasonography findings of the DIT, the inferior tendons. And second topic is the comparison between the ultrasonography guided injection procedures and or conventional toxin injection procedures. And last one will be the ultrasonography findings of the lips. First will be the anatomical findings on the upper masseter and DIT structures in a lower part of masseter. It is based on the two articles published in Toxins in 2020. This is a result. Based on our dissections, we could classify it into four patterns, actually two patterns. I'm sorry, this is type 4, this is type 1C. So type 1 is a superficial tendon cover the upper part of masseters, and you can see on the deeper part of the masseter here. So there was two patterns, type 1 and type 2. I will briefly show the dissection photos based on the this illustration. Yes, among these patterns, you can see the type 1 is predominant patterns. It means, so also based on our volunteers ultrasonographies, we classified into three patterns. Type A is about 21% cases. DIT, the inferior tendon within the masseter, appears anterior 2/3 of the masseter. Type B is 9% cases. DIT within the posterior 2/3 of masseter. The others, about 70% cases, DIT appears in the whole width of the masseter. It means in most of the patients, in most of the volunteers, you can identify the DIT, your attention.
Okay, thank you so much, Hee Jin KIM, Dr. Hee Jin. It's I think because of time limit, let's welcome another chair, Dr. Benjamin Ascher from France. Benjamin.
Yes, great pleasure to be with us. I think that CIASIA now is probably one of the most relevant association dedicated to the content of the minimal invasive aesthetic teaching. And I would like to point the fact that IMCAS do support concerning all activity of Prof. Huang and his board, and I'm sure that it will be very prominent source of content for the worldwide community. Let me just thanks one more time Inji Kim. It was anytime clear, very didactic. Inji, as usual. I think that we need to debate a little bit, but I don't know if we have enough time. So, Pohan, just let me know when it will be the appropriate time to debate. But it's a very good challenge.
Hi, my name is Sebastian COTOFANA. I'm an anatomist from the US. And unfortunately, I cannot be live with you on this session. The reason is, for me in the US, it's 3 a.m. in the morning while you see this. And this is why I decided to pre-record this session. And in this session, I will just briefly summarize the trends from 2020 and what it means for 2021. My research group, well, my different research group, we published together last year in 2020 more than 40 papers, which I'm very happy about, but just think about the thing, I mean, what are you going to do during the pandemic? Just write papers, right? And what I think was very interesting in 2020 was the different direction that anatomical research took. Because when you think about how anatomical research was previously done, was we dissected and looked at different variations or locations or relationships. And either it was done in embalmed cadavers, which was even less applicable to the clinical field, or it was done in fresh cadavers, which is a little bit more and more applicable to the clinical field. But still it was done in cadavers. And I think during the last years, and culminated last year in 2020, was that we started using other types of research. We used contrast agent enhanced CT scan of living patients, which is nice because it's really clinically applicable. The problem with this type of research is the fact that it is CT scanning, which is, of course, with radiation and the contrast agent is also a little bit tricky to inject and to have the respective availability of the data. But
yes, you're right. You know, ultrasonography guided injection is not easy for beginners. So there's a learning curve. There's, you know, many much experienced you know, clinical procedures. So we should study about the facial anatomy first, and also we should place the transducer during injection procedure. It's really complicated. So now I mentioned before, you know, dual plane injection. Normally we inject to the masseters, just touch the bone, only we inject, right? But when you touch the bone and inject, for example, when we during injection procedure, we use the 5 unit per 1 injection site, and the 2 unit above the bone and a little bit retracted 3 millimeters. That's enough. Yep. So 3 millimeter draw back and the 3 units again. So I think it is simple. Now I always doing in the cadaver specimen and touch the bone, 2 unit and a little bit draw back and the 3 unit. So I think there is a simple way to prevent the masseter bulging.
Yes, on a more practical approach, I would suggest that you can go to touching the bone and injecting the half part of the dosing, and then go to an other location 3 millimeter up. But in my opinion, with a retro-tracking permanent diffusion of the product, you are going to be more efficient without, I would say, the help of the ultrasonic system. So I think that it's good to go backward to 3 centimeters, but if we have a permanent retro-tracking, could work as well.